ladies and
You can
gentlemen,
start by the.
yeah. So, ladies and gentlemen, we start our program. For a short period, I was off the webinar due to some very personal reason, and I appreciate all the scientific committee members who took the initiative to carry on the work in my absence. We start today's program without delay, and hopefully we shall continue with our regular classroom henceforth. Today's classroom's topic is failure of endoscopic sinus surgery and revision surgery. And the speaker is Dr. Manish Singh, and the session will be moderated by Dr. Avidya Buragohai, the gentleman surgeon of Lakhimpur, who does not need any introduction among NABOI members. Dr. Avidya Buragohai passed MBBS from Assam Medical College, Dibrugarh, and he did his MS from the same college in the year 1987. He served 33 years in Assam State Health Services and retired in 2015 as the Joint Director of Health Services. Apart from all other conventional and ENT surgeries, he has quite a long years of experience in microscopic ear surgery and endoscopic sinus surgery. As I know him, he has a special interest in aesthetic surgery and attended many conferences and workshops in India and abroad also. He received LH Hiranandani Award in 1994 for his original work in nasal surgery. Presently working as a senior ENT consultant at North Lakhimpur. May I now request Dr. Avidya Buragohai to introduce the subject and the speaker, Dr. Manish Singh. Dr. Avidya Buragohai, please.
Thank you for your kind words. I feel privileged to be here as a participant and as well as a moderator to moderate this session. Today is an interesting session, a very, very hot topic. It is endoscopic failure in endoscopic sinus surgery and revision endoscopic surgeries. Actually, this is the subject actually where so we can find many things actually regarding the chronic disease rhinosinusitis, and if you go at in depth to this particular subject, everything will be known on the nose and the commonest diseases. And I think today our this particular session, the deliberation and presentation will be very much interesting and fruitful to all of us, because all of us are interested in this subject. And today's speaker and presenter is Dr. Manish Singh. And as all of us know, Dr. Singh, he is from Dibrugarh. And just to let you know about his biodata, I will just tell you, I will read out his biodata. He did his MBBS from Assam Medical College, Dibrugarh in 2005, and DLO from Guwahati Medical College in 2010. And he received fellowship in endoscopic sinus surgery, nasal-based surgery with Dr. T.N. Dankiram, Trichy, Tamil Nadu. Presently, he is working in the Brahmaputra Diagnostic Hospital in Dibrugarh. And he has special interest in sinus and skull-based surgery and OSA, sleep apnea. So I think I should hand over the microphone, and I should rather request Dr. Manish Singh to go ahead with his presentation today. Okay. Thank you.
Ma'am, can I start, ma'am?
Yes.
Thank you, Buragohai, sir. A very soulful start to this evening program with the loss of two doyens in our field. I hope everybody's having a very safe evening. And today's my talk is on failures in endoscopic sinus surgery and revision endoscopic sinus surgery. So why are we talking about it? So anybody who has been working in this field doing sinus surgery, they must be having patients who come after many year surgeries and still they are not satisfied. The symptoms are becoming worse and worse even after repeated surgeries. So by holding a talk like this, we want to help those kind of patients, and we want to be the ones who can tell them, okay, this is the thing. Now we want to treat you in a better way, and we hope for a better outcome so that they don't have to undergo another surgery, which is more devastating on the patients. So, why? I mean, what is the amount of problem we are facing in this revision surgeries and failed endoscopic sinus surgeries? As we all know that CRS is not a devastating disease. It is a devastating disease, but not a life-threatening one, unless until there are some complications arising out of it, like intracranial complications, which are not very common. But yes, it is very expensive surgery, so much so that in US, like 4.5% of the entire health budget goes into management of chronic rhinosinusitis, directly or indirectly. And the expenses of surgery per surgery in US is around $11,000, and compared to India, where it is on an average is around $1,100. And in a small town like Dibrugarh, we have to manage it around $600 to $700, including everything. So when we spend so much of money and so much of resources, and still we sometimes fail, that is 25% of the times we do fail. So it is one topic that we really have to go in depth of and try to understand the pathophysiology of this disease. Because CRS has recently, with the development of more techniques and knowledge, we have realized that the concepts are changing. So how do we define CRS? It is a chronic rhinosinusitis with or without nasal polyposis in adults is defined as presence of two or more symptoms, one of which should be either nasal blockage, obstruction, congestion, and nasal discharge, which might be anterior or postnasal drip, plus minus facial pressure or pain, and reduction of loss of smell for more than 12 weeks. Anything less than 12 weeks is not CRS. And we are not supposed to be doing CRS surgery for those patients. And another new classification which has come recently is difficult to treat rhinosinusitis. This is defined as patients who have persistent symptoms of rhinosinusitis despite appropriate treatment, which is recommended medication and surgery. So this is a new term, difficult to treat rhinosinusitis. So when we talk about these patients, this subgroup of patients who fail over and over again, we have to go and think, well, what is wrong with them? Like, what is the pathology behind these failures? See, CRS is not a single disease. As we all know that it is mostly related to asthma and airway diseases, the concept of one airway, one disease. So it is as such is not a single disease. It is mostly part of the more wider spectrum of diseases. And as our knowledge have increased, we have known that there are multiple endotypes like Th2 driven, non-Th2 driven, eosinophilic, neutrophilic, and we're still learning about those phases. And the learning will only help us to help these patients in a better way. And hopefully in coming years to come, we'll be so advanced that we'll not be requiring revision surgeries or repeated surgeries for these kind of patients. Yeah, phenotypes is what the patients they present us with, maybe with polyps or polyposis, AFRS, or things like that. And these patients are refractory, that's all right. But what can we do from our side? What we should not be doing is doing an incomplete or poorly performed surgery. We don't want to be the ones who do a case which is we are not happy with and which will not give good results to the patients. And so that's why these kind of classes and these kind of discussions are really helpful. One very important concept aspect of this patient and doctor relationship is what is the patient's expectation, because if the patient thinks that we'll operate and they'll go home like doing a tonsillectomy or appendicectomy and they'll be fine, it is not like that. It needs long-term treatment. It needs long-term nasal irrigation. If the patient is willing and he understands that there is a need for that, it's like an asthma treatment. They'll need the puffs. They'll need the occasional nebulization. These patients also they'll need occasional steroid therapy. They'll need continuous nasal irrigation for long term. If the patient is willing to understand, then we can go ahead and do surgeries. Yeah, changing trends. There are a lot of newer concepts that have come into CRS recently. Like maybe in 1980s, there was a thing of obstruction and infection of the sinuses that has really gone out of now. And so if that is not the case, there is no more role of any ventilation surgery. We cannot expect that we'll put holes in the ethmoids and expect the patient will be fine because we'll be giving the nasal steroids. That will not work. We need to make a cavity. We need to make a single neosinus cavity where the steroids irrigation does go inside. It is not only about CRS with or without polyposis. It is much more broader spectrum. It has now been postulated that it is only inflammation and inflammation with a lot of variety of genetic and immunologic contributions also. So now we know that it is an inflammatory disease as per our present day's knowledge. So how do we treat this inflammatory disease? We have to treat this inflammatory disease by giving anti-inflammatory, which in this case is nasal irrigation with steroids mostly. We can give steroids systemic also, but the best is giving irrigation. So for the irrigation to reach the depth of sinuses, we have to make a cavity which is accessible for nasal irrigation, for post-op viewing, where we can remove the mucus easily. And we also can reduce the nasal mucosal area, so there'll be less inflammation. And when there is less inflammation, there'll be increased mucociliary clearance. Yeah, when we talk about nasal sprays, this is the area where the nasal spray they hits. This is the area where nasal spray they hits. But then we want the steroids to reach the sinuses, which are box-like cavities, enclosed cavities. So none of these sprays which come in the market nowadays, they can reach these places because these are nasal sprays. They are mentioned as nasal sprays. They are not mentioned as sinus sprays. So to make this steroid reach the sinuses, we have to make an open cavity where the irrigation will reach the depth of sinuses and help reduce inflammation. So this is the current concept. This is very important, the EPOS 2020. I think we have already spoken about it in earlier discussions. I think it's a must for everybody to go through this. It's a 481 pages of literature, very interesting, easily available on the net, or if somebody wants, I can send them a WhatsApp copy also. But one should go through this because all the current concepts, the management protocols, a lot of things which were not present there earlier, like how to manage odontogenic sinus infections or pediatric infection, have been taken up this time. It is very interesting and it's very eye-opening. The current classification of EPOS, this is not a topic which I really should be dealing now, but since I'm talking about endoscopic sinus surgery, I have to talk a little bit about the current concepts. So I'll not go deep. I'll just say that it has been divided into primary and secondary CRS, which are quite understandable, localized and diffuse, and endotypes, which we don't have much idea about, but we are still in the quest to find out more and more, mostly type 2 or non-type 2. And even the secondary has been classified as in the same manner. So I'll not go deep into that, but this is something that we really should to know. There are some special kind of cases which I would like to just touch upon before we go into the sinus surgeries. This is a patient with looks like polypoidal changes in the tumor in the middle turbinate. It looks like so polypoidal that one might assume that this patient is having chronic rhinosinusitis with polyposis. But then when we go ahead and do a CT scan, it shows that there is nothing much there, just a little bit of edema. These patients, I'm mentioning because these patients really do very well with normal anti-inflammatory or anti-allergic therapies. Even nasal spray, they work well for this patient. They don't need to undergo any surgical procedure. These patients are difficult and they are the more common ones. We can see the central compartment atopic disease, CCAD. We see the center area, it is all inflamed, while the periphery of the sinus and a lot of the sinus mucosa is all normal. These patients are troublesome and it's difficult to treat, but with long-term nasal sprays, maybe steroids and things like that, anti-allergic medications, because it is associated with allergy in 90% of the cases. That's why I put these two sites in between. They don't need to undergo any kind of surgical procedures mostly. This is the patients we all love, this limited sinus disease, who we can all operate and patient will be very happy and they'll never have recurrence, but we hardly get these kind of patients. But yeah, these kind of patients need surgery and they'll have very good results. So what are the factors that affect our outcome in the endoscopic sinus surgery? The patient factors, disease factors, and a lot of factors which are the variables which we cannot control entirely, but we need to know them so that we can manage them better. Patient factors, we have to know about the history, how long the patient has been suffering, how is the patient's mental condition also, what are the patient expecting. If they think they'll be fine after the pack is removed, and it's not a case that we should be doing, because it's not like that. As I mentioned earlier, they need to have long-term treatment. The extent of disease, the sinus is involved. Is it fungus, osteitis, presence of biofilms, eosinophilic or neutrophilic infiltrates in the tissue? These things are important. I'll touch them during the pathological slides. Institutional factors, yeah, that's also there, because each institutions, they have different kind of setup, different kind of instruments, different kind of cameras. Some may have HD cameras, some may have 4K cameras. So they all ultimately they affect the result. The surgeon's ability, expertise, his experience. And one of the important factors is intraoperative bleeding. If there is bleeding, we have seen in a lot of studies that if the bleeding is more, generally the outcome of the surgery, the results also not very good. Anesthesia factor, I'll touch again later. And medical and post-op care is very, very important, which will affect the outcome in the endoscopic sinus surgery results. So how do we evaluate a patient of chronic rhinosinusitis? Age of onset, it is, again, according to EPOS, there are a lot of things they have discussed about the age of onset and different kinds of presentations. Early onset, mostly associated with allergy, and allergy and asthma, childhood asthma. And they do develop CRS, but then that is also mostly treatable with conservative management. And if the patient is having adenoids, that's a very important thing. We have to take that out if that is causing symptoms. Adult onset, mostly eosinophilic thing, and they develop very bad CRS with polyposis. And late onset, they're mostly environment associated, mostly neutrophilic. Infiltrates are present in the tissue, and which will help in the management of these patients better if you know what is the onset and what do we expect out of it. And how do you assess the severity of the patient? People use SNOT-22 score. It is very helpful, but personally, I don't really use it. I'll touch on my another table, which I'll show you. How do I go for it? Medications used by the patients, COX inhibitors, aspirin exacerbated airway diseases, respiratory disease is very important thing, because you have to rule that out before we touch any patients for CRS. Herbal medications, comorbidities as asthma, diabetes, autoimmune diseases, previous surgeries, and we should always ask if what are the documents available. If there is anything, we'll come to know what has been done previously, what was the pathology and what was done about it. Smoking, it is associated with bad outcome, and family history of atopic diseases, yes, immunodeficiency, cystic fibrosis, Cartagena syndrome, ciliary dyskinesia, and things like that, we should always rule out, or at least make sure if it is there also, we have to manage it in a better manner. This is the table I use, which is according to current EPOS guidelines. We say if the patient is having out of control symptoms, if he's having nasal obstruction present most of the times, anterior, posterior, purulent rhinorrhea, facial headache, olfaction, sleep disorders, nasal endoscopy shows disease mucosa, polyp pus or inflammation. Systemic medications as steroids are used regularly, like in the last month, then we understand that the patient is having out of control sinusitis, CRS, and that patient is more, we can take that patient up. So the patient has been chosen. Now we have to see what are the things, how we are going to go about it for the surgery. So for the most important thing is CT scan, pre-op CT scan. I think we have already discussed a lot about CT and MRI in previous classes. Like we should have thin slices, all three sections should be there, use of DICOM software to read. It is absolutely mandatory. It is absolutely mandatory to have a DICOM to see the CT films, not just the CT film provided by the radiology department, but all the cuts, how the structures, important structures are there. I have just mentioned a few here, but I'll go through each and all of them as we touch all the sinuses, like as we go up ahead. Yeah, basically, we should see the nasal septum first of all, the position, if there is any septal perforation caused by the previous surgery, location of inferior turbinate in relation to the orbital floor, presence or absence of middle turbinate, the uncinate attachment if it is still there after the previous surgery, entry ethmoid artery location because it is intimately associated with supraorbital ethmoid cell. If the supraorbital ethmoid cell is present, it is going to be in a mesentery hanging down and not stuck to the skull base. So that is a dangerous scenario. We should always see for Kiros classification, and particularly when you're going to the sphenoid, we have to see the carotid, the optic nerve, any kind of dehiscence. In ethmoids, you have to see the skull base, the orbit, and the frontal and sphenoid asymmetries bilaterally. Frontal sinus anatomy, which is all we know, is a very complex issue, and sphenoid intersinus septum, because sometimes the intersinus septum goes into the carotids, and presence of sphenoid, Onodi and hilar cell. It's going to be a very long topic. I hope I make in time, ma'am. The patient is taken up, chosen, done a CT. We've seen the CT. Now, next thing we do is preparing the patient for the OT. Before I take the patient up to the OR, I make sure the consent is rechecked. Patient has received his dose of antibiotics and steroid the day, and the antihypertensive medicines. The patient is hypertensive. I always make sure that my anesthetist, and he's a good friend of mine, he always keeps the patient's head up 20-30 degrees. There are a lot of benefits, as I'm sure we have discussed it earlier. And the patient is always given intravenous anesthesia, total intravenous anesthesia, no inhalation anesthesia. And if my anesthetist is comfortable, I'll ask him to give a laryngeal mask airway, and I request him to keep the pulse rate less than 60. Not always feasible, but then that's the best scenario possible. Sometimes I give beta blockers, if not contraindicated to the patients, at least a day or two ahead of the surgery. That keeps the heart rate in check during intraoperative period. Yeah, after the anesthesia has been given, I put the cottonoid soaked in undiluted adrenaline, unless and until contraindicated. Otherwise, I'll dilute it into 1:4. I'll put it in the middle meatus, in the sphenoid ethmoid recess, and the axil of middle turbinate. I do not give any kind of injections. Yeah, and this is a thing I do. A cup of tea for me after patient is under GA, and the patient has we have put the cottonoids in place, because I want the patient to settle down to his anesthesia. Because a lot of times I've seen, if the patient has just been given GA, and if you start going and operating on the patient, the heart rate is somewhere, the BP is very high because of intubation, a lot of reflexes, they work. So I want the patient to settle down, maybe take a time of around 5 to 7 minutes, and then go ahead and start the surgery. There, now the patient is under GA. Now, what we have to see? What are the anatomic factors contributing to recurrent chronic sinusitis in this patient who has already been operated? So we have to see. Most commonly, what I find in my practice is retained uncinate. Invariably, most of the patients whose uncinate has not been removed totally, they will have a recirculation phenomena, they will have a secondary ostium, and that beginning will ruin all the other work also, all the other sinuses, they get infected from there. So retained uncinate, you have to check for that. Incomplete agonized resection or ethmoidectomy, the bulla is incompletely removed, or the middle turbinate is lateralized even after a proper surgery. Sometimes the middle turbinate is not managed properly during intraoperative period. It tends to lateralize and block the ostium. Frontal sinus outflow tract can get obstructed. That's why, as I mentioned earlier, I never want to create a circular cavity in any of the sinuses. If it's rectangular, it is very nice. At least oval or pear shaped is better than a circular cavity. It tends to shrink very fast and obstruction tends to occur. And maxillary recirculation, as I mentioned, because of secondary osteum creation sometimes during surgery. Post-op synechia, new osteogenesis. Yeah, new osteogenesis is very important because it is very hard to deal with, first of all. And it is very common. It occurs mostly because of the severe infection which goes into the bone, which starts creating new woven bone formation. And that causes more and more obstruction. And one more thing, even if we don't take care of the mucosa, that is, mucosal sparing surgery is not done, it will cause more new osteogenesis. Recurrent mucosal disease. Now, since we are doing a revision endoscopic sinus surgery, what are the anatomic landmarks we can rely on, which will always be present, irrespective of number of surgeries performed on the patient? For me, my favorite is medial orbital floor and the plenum sphenoidal. But nasal floor is also, we can, if nothing is there, we can go through, like we can assess where the nasal floor is and then go laterally, go hunt for the maxilla. Then we find the middle orbital floor and we can go ahead like that. Similarly, septum, which is always the medial boundary of any kind of draft procedure. And posterior maxillary wall, yes, and lamina papyracia. Yeah. So these are the important landmarks which I'll discuss as we go ahead and see all the respective sinuses. Coming to the maxillary sinuses, first and most important thing, we have to see where the attachment of uncinate process is. There are a lot of variations, but what I think, whatever the variation is, it has to be removed in toto, incomplete. It's like if we follow the uncinate process from below upwards, we can do it irrespective of the attachment. And once we do it, it'll open up the pathway for our frontal sinus work. Lateralized uncinate, very dangerous if the patient is having silent sinus syndrome. If we use a sickle knife, we'll straight go inside the orbit, high chances of that. Like trimal duct, our teaching was like to put the back battery and come back till we get hard bone. But unfortunately, that hard bone is not hard all the time. So sometimes we have to be very careful. So that's why I use the maxillary line as an identification point, because the uncinate attaches anteriorly to it. When I reach the maxillary line, I know that the uncinate has been, I have come to the boundary of limit of the uncinate process. I don't go hunting for the hard bone. Infraorbital ethmoid cell, Heller cell, which obstructs the outflow tract of maxilla. And we have to always identify the natural ostium using angle scope. We have to make sure that what we're seeing is not an accessory ostium. And as I mentioned, round opening should be avoided. Enterostomy size, I try to make as big as possible. There is no consensus on a particular size till date. And what are the advanced procedure for these recurrent diseases? As we have already seen in previous meetings, we can go for a wide MMA, inferior meatal enterostomy, but then that might not be physiological, but still helpful in the patient's secretion are very thick. Medial maxillotomy, modified Denkers, even in previous presentation, I have shown about it. If I have time, I hope to show a little bit if possible. Nowadays, I've started doing this posterior inferior turbinectomy. I removed the posterior third of the turbinate. Then I drill the inferior middle wall of the maxilla. And then I cover it with a flap which I've taken from the nasal floor. It fits very well because normally in the maxilla there's a huge sump which goes in the medial side or the medial end of the maxilla. So we can remove the sump and so there'll be better drainage. I'll try and this is a CT of a patient with silent sinus syndrome. We can see on the left-hand side how low the orbit is compared to the other side. If we try and enter the sinus using a sickle knife, we might invariably end injuring the orbit. These kind of situations we have to be very, very careful about. So I hope I'll be able to show a little bit of surgery. Yeah, this is how I do the first step of my surgery. How I do DNA. Is it
We are not seeing your video.
Can you get the video?
No, we are not seeing.
Can
Video is
you
not
get the
coming.
video, sir?
We are on the slideshow.
Manish, video is not
Okay.
coming.
All right. Still, the slideshow is there.
Slide
see
is
it,
still
sir?
there, Manish. We are seeing the silent sinus syndrome slide.
Okay, sir.
Manish, if it
You
is
can't see the video, sir.
Manish, if it is in that slide only, you have to make slideshow. Then only it will run. Try this. Make it slideshow.
Oh no, it's not in the same slide. I've kept it. I've
Okay,
kept
then
it
then
separately.
you have to if you kept it separately, then you have to stop sharing. Again, share the slide and click on that particular video if
Okay.
it is in your desktop.
Okay.
You just
You,
open your video folder, then stop the video and slide share while sharing. You click in that particular video, then only you will be able to see.
Mhm. No, it's not slide share.
You will get your desktop picture.
Sorry, sir.
You are not sharing
Hello?
your slide. First, you share your slide, then click on the particular video.
Just a second. Now is it?
Yeah. Now
coming?
you keep on. Yeah. Now keep on playing.
Yeah. It's can you say it now?
Yes,
Yeah, you
yes.
can
You play the video.
Yeah. Is it okay now? This is a DNA. This is the first pass of the diagnostic nasal
You
endoscopy.
minimize the
Video
the
to
video is not playing.
play the video. Play one eye.
মই play কৰিছো ma'am.
Oh.
I think you have to minimize it. It's behind your.
Manish,
Sir?
once you start the video, then share the video, not that this is screen. Then share the screen. You have the options to share screen.
Laptop or to page to me minimize kora.
Okay.
It is video and minimize this screen. Minimize this
Minimize it.
folder.
Yes.
Okay.
Minimize this folder.
Yes. Minimize it.
Is it okay now?
Naiwa.
Manish, stop sharing this screen, this folder. So you just play the video in VLC media, stop it, and then share the video. Stop sharing now first. Manish,
Okay.
please
Cancel
stop sharing now.
Yes.
Now you have a video. Now go for sharing again.
Now for sharing again.
Then you have show the video. This
Okay.
VLC player, in the VLC player or any video player. This video player.
Now share.
No, already sharing.
I said.
And you
It's
can
coming
optimize
now, huh?
because there's lagging. Manish, I have told you now.
Yeah.
And there's the option called you go up and there's option optimization because it's lagging. It will take time. Yeah.
Okay.
It's okay.
Okay.
I can go explaining.
Yeah, this is a DNA. This is a DNA. I can see the sphenoid sinus also here. So next I'll show about the basic MMA. Okay. Can you see, sir, now?
No.
You haven't shared.
Share again.
Okay.
Play the video in BLC and share again.
Now?
I think it will come.
Yes.
Yes. I cannot optimize. This is the time I used to give injections, but now we have something in. Can you see it? This is how you use a backbiter. Hello? Bisura, can you hear me?
Yes, yes.
Okay.
We can hear you.
Yeah. We don't remove the entire uncinate with one go. I prefer to keep the lower border of the uncinate and make the MMA as wide as possible. This is a very old video though. I was using a lot of sharp instruments, but now mostly we use true cut instruments to widen the thing and then use the debrider to come and mop the rest of the thing. Just for tissue. This is how we take out the uncinate bone. And we can draw in it. This uncinate bone. We widen it posteriorly to the posterior fontanelle. Yeah. Okay. We'll get back to the next sinus. Can you hear me still?
Yes, yes, we can hear you.
Hello?
We can hear you, Manish.
Yeah. Yes, ma'am. Thank you, ma'am. So when we come to the ethmoid sinus, first and most important thing, we have to see how the skull base is because it forms the roof of the ethmoid, the entire area. And for that, we have to see the Kiros classification. Numbers to remember here is 4 and 7. Anything less than 4 is type 1, more than 7 is type 3. And as we go, I think, as we go to type 3, you can see that the skull base dips down very vertically. We have to be very careful because we might injure the skull base in these kind of presentation. But I think it's the more acuteness of the skull base that should be remembered rather than counting by millimeter and centimeter how much it is. If you see a very acute bend in the sinus, in the ethmoid skull base, then we should be very careful, and more so if it is unequal on both sides. Because what we tend to do, if you're doing one side, we tend to think, okay, this is the level we have to be careful about. And suppose the skull base is more on the lower level on the other side, we might just injure. There are high chances of injury. We have to see the integrity of the orbit, the lamina papyracea, because it tends to be dehiscent in 6.5% of the cases. I'm talking about the non-surgical, non-post-op patient. Even naturally, there might be 6.5% chances of dehiscence. And the medial rectus in these 30 to 40% of these patients tends to be in the dehiscence. So we have go from anterior to posterior, we'll see how superficial it becomes, and there are more chances of dangerous injuries in the posterior area. And we have to make sure that anterior ethmoidal artery is not in a bony canal, not hanging in a mesentery, as happens when there is supraorbital ethmoidal cell present. When we think about ethmoid surgery, we have to put a lot of considerations that we have to make sure that a lot of things to be done properly. We have to remove the entire ethmoid bulla, all the walls, and we have to see make sure that the basilar lamella is entered at a lower level. And then we have to identify the skull base in the posterior ethmoid region, and then skeletonize all the ethmoid lamella and as we come anteriorly, making sure that mucosal preservation is done as much as possible. Taking the example of a box to know about the anatomy of ethmoid is very helpful, at least so that we know what the limits of our surgery is. Because as if we compare it with the box, we'll see that if we compare it like a box, if we see the right side of the sinus, that the lateral boundary of the ethmoid is lamina papyracea all throughout, and the medial boundary is the superior and the middle turbinate, which both lie in the same sagittal plane. It is always in the same sagittal plane, and the superior boundary is always the skull base, and behind lies the sphenoid sinus face. So if we are sure, we know that we have found the sphenoid properly, even if we have not completed the ethmoid work, we can come back and remove all the lamella, ethmoid lamella in front of it till we reach the anterior part. Then we can start dissecting on the frontal recess area. Yeah, this is what I was talking about, the middle, the middle rectus muscle and the orbit. See, this is the anterior cut of a patient CT scan, and these are as we go behind posteriorly. See, this anterior cut is, we can see that how much the orbit jets into in a nasal passage. So this corridor is very small compared to the posterior ethmoid region. But then here, we see that the middle rectus is separated by a pad of fat from the lamina. So even if we injure here inadvertently, we might be lucky to get away, that only a little bit of fat will prolapse inside. But same injury, if it happens in the orbital apex region, we see that the middle rectus is absolutely adhered to the lamina. So it'll just suck in the debrider, it'll get sucked in the debrider thing, and it'll cause a lot of injuries. I am talking about this because I have myself underwent, I have had my patients who had some medial rectus injury in the initial days of my practice, which is very devastating for the patient and the surgeon.
Manish,
And we are liable for medical. Yes, ma'am.
Manish, your
Hello.
video is on in the screen actually. When you are showing
Oh.
any CT scan, your video is on.
Oh. Okay. Now, is it okay, ma'am?
Yes, yes, fine.
It is fine.
Can you see my?
Yes, CT scans, yes. Full screen? Okay.
Can you see now, ma'am?
Yes. Now we can see.
Okay. So, did you get the point, ma'am? I was talking about the middle rectus and the orbit.
Yes.
Hello. Okay, ma'am. So, ethmoid surgery and sphenoid surgery are very related. So, I'll not be showing any surgical steps at present. I'll show when I'm done with the sphenoid sinus anatomy. So, coming to the sphenoid sinus, how the CRS is connected to the refractory CRS is connected to sphenoid, because many times we all surgeons are very scared of touching the sphenoid sinus, because we have always been told that optic nerve, carotid artery, but the fact of thing is all these structures are way behind the posterior wall, and we are nowhere near when we are dealing with chronic rhinosinusitis surgery in sphenoid. So we don't have to worry absolutely about it. We can go inside, but we have to be careful. We have to know the CT scan. If the optic is dehiscent or the carotid artery is lying inside, there are chances of that. But if we are sure about the anatomy, then we can definitely do this sinus. It is not something to be scared of. In fact, it's one of the most helpful anatomical relations that you can get out of in the face anatomy, in the sinonasal anatomy. Anyway, according to Hammer and Edberg, there are three kinds of sphenoid sinuses. This one shown is the pre-sellar. Conchal will be entire bone, and the sellar is the most favorable one for us. Yeah, this is the posterior wall of the sphenoid sinus. You can see the optic nerve, the carotid protuberance, and the planum sphenoidale, the clivus cellar floor, and the OCR between the optic nerve and the carotid protuberance. See, this is a sagittal section of the patient with like, this is just to show that how posteriorly are these structures. We are only dealing with the anterior wall, anterior face of the sphenoid, and we can remove all the mucopus or polyp which is inside it without injuring these vital structures which lie back. So we don't have to be so scared of, even if angiofibroma enters the sphenoid sinus, it never gets attachment. We can always just pull it out, unless until it is abutting the carotid, but mostly we can just pull it out. So this is again a slide which shows that the carotid is so way back behind. Not this is the entry face of sphenoid where we open the ostium, and this is so behind that we don't need to worry unless until there is a lot of dehiscence and everything is lying inside the sinus cavity. We have to be very careful about this particular scenario on Onodi cell. I'll show a video also of it. There's a horizontal septation. Whenever we see a horizontal septation in the sphenoid, we have to be very careful about Onodi cell because it tends to pneumatize with the optic nerve, and in these cases, optic nerve lies dehiscent in the Onodi cell. Sometimes we open the Onodi cell and by mistake, and if you're not aware of the anatomy, we can injure the optic nerve, as shown in this picture. It's not very clear, but it's just how the relation of the Onodi cell and the sphenoid sinus is. This is, I think, a very nice schematic diagram of showing how the Onodi cell pneumatizes on the sphenoid and its relation, and how it pneumatizes the optic nerve, like around the optic nerve. It is a posterior ethmoid cell that pneumatizes lateral, posterior, and superior to the sphenoid sinus. There are high chances of optic nerve injury if we inadvertently enter the cranial, and we might also enter the cranial cavity thinking it's a sphenoid, thinking it's a posterior ethmoid cell, and we still haven't found the sphenoid because we don't see the optic, and there are high chances that we might just enter the skull base. Sphenoid intersinus septum inserting into the carotid is also one of the most very dangerous positions, because if we are not aware of this and we take a sharp a blunt instrument and try to resect it, there are high chances of carotid artery injury. But talking about sphenoid sinus, there are two very important things that we should always know. If we are finding it difficult to find the sphenoid ostium, first we find the orbital floor, open the maxilla first, find your roof of the maxillary sinus or the floor of the orbit, and at the same level and medial to the superior turbinate, we will always, there is no exception, we'll always find the ostium of the sphenoid sinus. And once we open the sphenoid sinus, open it broad, and then we find the planum sphenoidale, which is the lowest part of the skull base. And once we find the lowest part of the skull base, we can easily come anteriorly and clear all the ethmoid lamella, do a complete ethmoidectomy, and then go to the frontal recess. I'll try and show a video here. This is one patient where we had a hard time because it was a revision case, and intraoperative blood pressure was very high, a lot of bleeding.
I haven't got the video. Video hasn't
Yes,
come.
I'm trying to. Okay. Now?
Yes.
Yeah, I'll
Play
start the video. Can you see the endoscopic view?
Yes, yes. We can see.
Yeah, this patient, we had a hard time. It is a lot of osteitis. You can see this. This is the orbital floor. I have already opened the maxilla, and there's a lot of osteitic bone here. and the patient was really hypertensive, old patient. We had a very bad time. I'm showing this video because it can be very difficult at times just to find what the normal anatomy is. So I'm trying to find the here. I'm trying to find the superior turbinate behind the middle turbinate so that I can go to the sphenoid from here. But then I get so frustrated trying to search it. I can't find it. That I decided to take the medial approach, knowing that my orbital floor level. I'm still trying to assess what is the anatomy. Can you see the video? This is it?
Yes, yes.
Okay. Then I'm just checking on my orbital floor level now, like just to make sure I enter the sphenoid ostium, the right place. And a lot of inflammatory granulation. So now I'll use a J curate, which I find very safe. Slide it on the area I suspect, and yeah, there it is. We can see the air bubbles coming out because it's a sphenoid ostium. So, and more so because I was more particular about this case because I knew that there is a Onodi cell also, and I'm using. Can you see now? Can you see the video?
Yes, yes. We can see.
Yes, I'm using a I'm using a mushroom punch to to open up the sinus wide, so I can see all the boundaries. Yeah, and since this patient also had a Onodi cell, can you see the video, ma'am?
Yes, yes, we can see. We can see.
Yeah, yeah. This is since I know that my sphenoid is behind me, I can safely remove these ethmoid amyla in front of it. I'm using a true cut forceps to create a bone mucosal soup, and then my debrider comes in and it takes it off. It's pretty easy. It's easy on the debrider. Once we know the anatomy and we know what is our boundaries, I can see the sphenoid now here. I know that's my sphenoid. I know there is a Onodi cell from my CT, pre-op CT. I know where it is, so I'm just trying to wiggle it there and try to take it out. Yeah. This was a very uncomfortable surgery for me because I was having a hard time. So again, I try to crush the mucosa before using the debrider there. And I know what is it there. I know that the Onodi is there. So there's the Onodi. This is sphenoid. Now I know what is my posterior boundary. Exactly. I know my lowest part of the skull base. Now I can easily come up and remove all the ethmoid lamella in front of it without any danger. Once you know your landmark is there, you can be so comfortable and so much relieved also in this, particularly in this kind of scenario. Okay. So okay, now, all right. Now coming to, can you see my slides, man?
Close the window, computer window. Your video window is okay.
Okay. Now is okay?
Yes.
Okay. Share screen. All right. So this is okay, ma'am?
Yes, yes.
Okay. Now coming to frontal sinus, we all know how complex anatomy is, and it is always, I think for all of us, it's the most difficult sinus to access, simply because we have to use angle instruments, angle telescopes, and things like that, and difficult anatomy. And plus there is so much of variation in anatomy, so many kind of types of cells which are there, so many classifications. But we should always know the boundary, what are the boundaries of our dissection. And kind of access also depends on the pathology of the patient. And but one thing I'll like to mention, that before, like we always decongest our middle meatus before doing unsphinctectomy, I think I'll always prefer to put a cotton patty, just slide it up the bulla before I do anything else in the starting of the surgery, so that it really decongests the frontal recess by the time we reach it. What complicates frontal sinus? This is a pathway, frontal recess pathway. We know there is an agar cell there, almost always consistent. The uncinate and its attachment and accessory cell type, those frontabular cell, and those type 1, 2, 3, 4 Kuhn cell. And there's so many classifications, but if we know what boundary, what are the boundaries of the resection, then we can just simply take out all of those cells, whatever the number is. But two things that we should be careful is type 4 cell and supraorbital ethmoidal cell. I'll come to that. Again, like we had a horizontal box for the ethmoid. I'll mention about a vertical box for the frontal sinus. The frontal sinus outflow tract is always medially bounded by the middle turbinate, and laterally we have the lamina papyracea. So that's our lateral and the medial limits of our dissection for frontal recess. Anteriorly is the nasofrontal beak, which we drill in all those draft drill out procedures. Posteriorly is the skull base or the posterior table, which is in fact the continuation of the posterior ethmoidal, the ethmoidal skull base. That's why when I was mentioning, it is always mandatory that we clean up the ethmoid lamella, all the ethmoid lamella very clearly, so that we have a skull base we can follow anteriorly and be sure that is a posterior skull base or posterior table of the frontal sinus as we go up, not a supraorbital ethmoid cell. Frontal sinus classifications, so many classifications, Kuhn's classification, type 1, 2, 3, 4. I'm sure we have already, everybody of us has already gone through that. The supraorbital ethmoid cell is very important. And type 1 is single frontal cell above the agar nasi. There are tier of cells in frontal recess above agar nasi is type 2. Type 3 is a single massive cell limitizing into the frontal, and type 4 is an isolated cell in the frontal sinus. So this is one classification which has changed totally by PJ Wormold and his group. This is from his textbook. This is a much more logical, because they have classified it as agar nasi cell, supra-agar cell, supra-agar frontal cell, which goes inside the frontal sinus, like type 3 or type 4. Posterior cells have been like divided into suprabular cells. anyway, whatever the classification is, but if we know what are the cells to be removed in between those four boundaries, behind the nasofrontal beak and in front of the posterior ethmoidal skull base, we can safely do frontal sinus dissection. This is the supraorbital ethmoid cells. Like we have to be sure about this as we see in the CT, because it's not such a common thing, but if present, we have to be really careful. As I mentioned about the horizontal septae in sphenoid sinus showing an Onodi cell, in the frontal sinus, it is the supraorbital ethmoid cell. One way to know that this is a supraorbital ethmoid cell, not a frontal cell proper. I mean, this is what I follow. May not be true all the time, but if we can see the maxillary sinus, it is not the frontal sinus. Invariably, if you can see the maxillary sinus, if the CT is done in a proper way, it is never the frontal sinus. Once we start seeing the maxillary sinus properly, the frontal sinus should not be visible in the CT scans. So if you still see something which looks like frontal, not very sure, mostly it is supraorbital ethmoid cell. So how do we proceed with the surgery? There are various various procedure to access the frontal sinus. Type 1 is anterior-ethmoidectomy, which I have been mentioning. Anterior-ethmoidectomy, do the posterior-ethmoidectomy, everything, all the ethmoid cells. If you remove all the ethmoid cells properly, that's without even touching the frontal recess. That is draft 1. And draft 2 is when we create an opening between the lamina papyracea and the middle turbinate incision. That is, we start doing instrumentation in the frontal recess. Then is draft 2A. Draft 2B is when you remove the sinus floor. That is, we have to pull out our drill. When we start those drill procedures, then it is 2B. And when we connect both the sides of this, it becomes draft 3. So in relation to CRS, I don't think so. Draft 3 is, or modified Lothrop is so important. Or yeah, there are many extended approaches, like in this patient who had a sinus leading into the frontal sinus from the skin. So what we did the approach was already open. There's already a discharging sinus. So we assessed from up and down both. We did maybe a draft 2B, and we opened the sinus. We got a lot of osteoneogenesis in the recess. We removed all those things. And this is how frontal definition is done also by a stab incision in the medial eyebrow. We can do a frontal definition for more extensive disease, osteoplastic flap, frontal sinus obliteration using the pericardial flap, mostly done by neurosurgeons for that, various pathologies. And yeah, not so much important when we talk about CRS. Again, when we talk about frontal sinus surgery, we have to know our boundaries. Medially is the nasal septum, which becomes into intersinus septum. Laterally is the lamina papyracea. Posteriorly is the ethmoidal skull base, which turns into the posterior tabular frontal sinus. Frontal sinus surgery, I would like to show, if possible, here. Yeah, this is. Can you see the video? Hello.
Yes.
Yes.
Yeah, these are. This is the middle turbinate and the nasal. Video is I'm not very sure about which is the frontal recess, but I know my boundaries, and I'll stay in between to the boundaries and try to dissect and see what happens. And as we dissect more and more, and yeah, this is the frontal. This is a frontal sinus. We can be sure about it now. But there's still an opening, small opening. I want to broaden it more. If time permits, I show a draft procedure. But it is difficult because we are using a 70-degree scope. and my 70-degree scope is not the best, and we have to use all the angle instruments. It's sometimes very difficult to align yourself to that. Anyway, so I'll go back to my presentation. Can you see my this thing PPT,
Yes,
ma'am?
yes.
Okay. So since I'm talking about revision surgery, I cannot miss navigation surgery, though it's not available with us here. But it is, yes, definitely very important, particularly in bad revision cases, multiple revision cases, or when there is pathology which abuts the carotid artery or optic nerve, or it goes into skull base. Yes, it is definitely very useful, but nothing can take away the idea of anatomy that we all should have when we touch this very complicated area. So yeah, it's a handy but very expensive, and yeah, it depends on the surgeon. If he's sure that he can manage it, then yes, he might not need it so much, but definitely a handy device to have. So all done with the surgery, and how do we do the post-operative care of the patient? I think it is the most important part of the management, and in which we mostly fail. I've seen a lot of patients who underwent good surgery, but then due to lack of follow-up or things like that, outcome is not really good. So for me, immediately post-op, I generally do not pack the nose if I'm doing limited osteometal complex surgery or localized surgery. I just place some Surgicel and let it be like that. But if it is a full house fess or extensive disease, if I'm doing abdominoplasty or something, I make sure I put the Merocil there in place for 36 to 48 hours. IV antibiotics, intraoperative, postoperatively, I give cefuroxime or amoxiclav, and then later all antibiotics. Systemic steroids, I give injectable when the patient is admitted, and on discharge, I prefer giving deflazacort, which gets tapered off later on. Anti-inflammatory, analgesic, and anti-inflammatory medications also. So I start on the patient with high volume nasal irrigation, at least 240 ml of saline with budesonide 500 microgram, not immediately, but third post-op day, for twice a day, at least till a month, and then I follow up the patient and then decide on at least once a day is continued for 6 to 8 months with a regular follow-up. One very important thing is 1 week after I call the patient, I take the patient to the OR again. I do endoscopic examination and remove if there is any clots, or if there is minor synechia, we debride the synechia also. And then we follow after again every 2 weeks till 2 months, and then I ask the patient to come for regular checkup lifelong. Yes, as I mentioned earlier, role of histopathology is very important. That's according to the new EPOS guidelines also. We have to know what it's not about knowing that we, even before we send the patient's sinusal polyp for pathology, we all know that it is a polyp. We don't want the pathologist to give us a report that it is sinusal polyposis. We all know that even before we send it. What we need to know is what kind of infiltrates are there. Is it eosinophilic infiltrates? Is it neotrophilic? Is it CL crystal, charcoal crystals there? Any kind of granulomas or foreign body reactions, because they all have different kind of management. If it is eosinophilic infiltrates, a lot of eosinophilic infiltrates, we have to manage it in a different way. We have to use anti-allergics or things like that. I'll take the help of my immunologist or allergic doctor, or even my pulmonary specialist. They have more idea about all these things. If the patient is neutrophilic, having neutrophilic infiltrates, we know that a lot of studies which prove that clarithromycin works wonders in these kind of patients. Charcoal crystals also shows that there's a lot of allergy, and it's also associated with asthma and things. So these things are very important as we follow the patient up for a lifelong thing, and we want to give them good results. We need to know everything. So again, this is what I do in a nutshell. I showed in the videos, but I want to just remind how I manage these patients. First of all, in any surgery, I do a DNE. First step of my surgery is lateralization of the inferior turbinate, so I get more space. Then I do the MMA and I make it wide. I find my orbital flow. I remove the bulla. Sometimes it is not there, but invariably it's there. We just do complete bulla removal. Then staying below the orbital floor level, I go and hunt for my superior turbinate. I don't go up at all around this time. I find my superior turbinate, part of the inferior part of the superior turbinate sometimes needs to be trimmed. I trim it. Then I find my sphenoid ostium, and then I go a step up. Already I find my one floor in the middle orbital the orbital floor. I know. Next up is the plenum sphenoidal, which is the lowest part of the skull base. So if we stay below it, we'll never injure any skull base structures. And since we know the lowest part of the skull base, we can just come anteriorly to it, remove all the ethmoid lamella, clear off the roof, ethmoid roof, and we have a nice skull base totally exposed. And then we do the frontal recess works, which becomes very easy if you remove all the ethmoid cells, because all these type 1, type 2, type 3, type 4 cells are basically ethmoid cells. Free of anything modified left as per the pathology. So this is a long topic. I tried to complete as fast as possible. I tried to cover as much as possible. I hope I have done justice to this very huge topic. Thank you so much for giving me a chance. Thanks everyone.
Thank you, Dr. Manish. Thank you, Dr. Manish. You have nicely presented the subject. So I hope we have all enjoyed your deliberation, your presentation. Now I think now our session is open for this discussion with this question and answer session. I think Anjana will take up now with the questions.
Okay. First question was from Akhil Samasar. Which group of patients really need surgery and when? We overdoing it? Are you getting me?
So it is how ma'am? Which group of patients? I think patients who are not getting well with their appropriate medical therapy, people who falls in the severity, in the very uncontrolled group of the severity chart which I showed, I think I'll take them to surgery earlier. I'll not wait 3 months or 4 months for that, because I need to start the anti-inflammatory medications reaching all the nooks and corners of his sinuses, because that's the best way for this. It is an inflammatory disease. We have to make the steroid reach all the corners. We can give them systemic steroids, but then that systemic steroids goes into his liver also, it goes into his eyes also, causing a lot of complication in those areas. So what best can be done? We remove all these polyps, make the sinuses wide open, and let the topical irrigation take its work.
Sir, if you are there, are you happy with the answer?
It is all right for the polypoidal diseases, but for non-polypoidal diseases,
yes,
if you find that the disease keeps on recurring and you have to give systemic steroid once, twice, or thrice, then you must go for surgical procedure.
Yes. That's the severity score I was talking about, sir.
Yeah.
If patient is having uncontrolled, very severe disease, yes, we should. So much of systemic steroid requirement, I think we should operate.
I think so, yeah.
Dr. Hemanta Mohan was asking role of surgical management in children.
Surgical management in children is very controversial. I personally have a very high threshold for doing endoscopic surgery in a child. I will not mostly. But if the patient is having adenoids, definitely I'll remove the adenoids, because that adenoids is also harboring a lot of biofilms, which can cause so much of sinusitis, CRS. Sometimes just removing the adenoids is good enough. But otherwise, I'll try and avoid as much as possible. unless until if the patient is having, even if the patient is having cystic fibrosis thing, then I'll make a very wide, all the like full house fist, big wide fist, and let the topical irrigation work. But otherwise, I will not be operating very early in a child.
So the first suspicion should go for adenoids always. If there
yes,
is
adenoids.
Whatever sinusitis has developed will automatically
yes, yes, sir. Yes, sir. Even in adults, we should be very careful about adenoids because I've seen a lot of patients, a lot of adult patients. In fact, I operated my anesthetist, my own anesthetist, at his ripe old age of 37 or 38 years. So he had huge adenoids.
SB Fukan sir wanted your opinion. Recurrence is mainly due to anatomical abnormality or disease process.
So that's what CRS is not a one factor thing. It is multifactorial. It is disease process, is anatomical abnormality, and yeah, mostly it's as I mentioned, sir, it is mostly a combination of multiple factors. It can be both. I'll not say it's a single factor.
Biraj Das sir has commented that follow the roadmap in CT and proper hemostasis, then one can achieve successful surgery. Keshamananda has
yes.
asked one question: does Kiro's classification actually helps in surgery?
No, that's what I said. I think it's a slope, it's the acuteness of the slope of the ethmoid skull base, which I normally see. I don't go for Kiro's classification, but it has to be mentioned, so I did.
Shagata madam has mentioned selection of patient is another factor for failure. Patient with migraine, also mesenteric rhinitis and allergic rhinitis.
Yes.
Akhil Sharma
That's
sir
why.
has. Okay, anything to add?
No, that's why, ma'am, I've been mentioning about this new EPOS classification, which touches a lot of these other pathologies also. So it is a very important document. It's big, but then it's worth reading. So a lot of things have been mentioned there.
Akhil Sharma sir has asked about Onodi cells. You have already mentioned about that, I think, in your presentation.
Yes, there was a video also.
SNOT 22, what is 22? SB Fukan.
It's not there. There are 22 a number of the questions we ask the patients. A lot of his things, his sleep, how does he feel about it? Is he having depression, nasal obstruction, olfaction, and things like that. I don't really follow that, sir, but we can use it. Definitely, it has been used widely worldwide.
I think it has got some
22
prognostic.
questions we ask the patient.
It has got some prognostic.
Yes, sir, it has.
Because you can compare your results afterwards. That how many symptoms have gone.
Grading.
Yes, sir, but the kind of set of patients we know, like what we deal with is, if you ask him, how do you feel next morning? It is very strange. You'll get strange answers. So I don't really, maybe in a very educated, well-educated society, it does work well. No, it has.
Usually a questionnaire should be prepared and should be given to the patient beforehand, before examination. And then you should quickly go through the questions and verify that whether he has replied correctly or not, because he may change his mind sometimes when you are asking the questions directly. So you give the questionnaire first and let him fill it up, and then later on again ask. But it is quite helpful. That is what I have found. It is quite helpful. I think all of us should do it, actually.
Yes, sir.
Thank you.
Biraj Das sir has mentioned.
It is in all the literature has been mentioned. It's not 22. Definitely. Yes, sir.
Biraj Das sir has mentioned Kiro is theoretical. Anatomical orientation is rather more important. And Akhil Sharma sir also mentioned it is better to identify the sphenoid ostium before removing the posterior ethmoid. Sphenoid ostium is at the level of the superior maxillary. If you have anything to add on that.
Right, he has already mentioned that you have to go medial to the
then come
middle turbinate and then
yes,
identify it, but you should not forget about the superior maxillary line. So it is at that level.
yes, yes.
Okay.
Yes, sir. That's what I showed in the video. It was a hard, difficult surgery, but that landmark they showed me that the sphenoid is there. I can just go in there carefully, knowing that there is an Onodi cell also. I have to be more extra careful because I don't want to disturb the posterior ethmoids, knowing there's an Onodi and I can't find my sphenoid. So I go to the sphenoid, found my boundary, go for the Onodi, and then come front.
Fukan sir has a query. How you detect it as neutrophilic or eosinophilic? Histopathological, I think.
So we have the pathologists. I spoke to a pathologist, and they can give a report like that. Okay, there is a lot of eosinophilic infiltrates or neutrophilic infiltrates in the tissue provided.
I think microscopically.
Or the presence of Cl crystals and things.
Nitesh sir has mentioned it's a wonderful and well-researched presentation. So he has asked, how do you manage CCAD cases?
Thank you.
Central compartment and atopic disease.
Central compartment atopic disease, I generally am conservative about it. I give personally, I give nasal sprays, a short course of steroid if required, but don't take them up for surgery drastically. If the patient is recalcitrant, I might consider giving him a choice, but I'll still be more bent towards
Lots of compliments. Fukan sir has mentioned it's an elaborate and nice presentation. And Kesavananda has mentioned excellent. Manish very elaborately covered the subject. And I think last question is from Gotamda. Well done. How do you do counsel a CRS patient?
So counseling a CRS patient, as I knew you will be asking something like that. So it's the most difficult part because we all know how the disease process is. It is I give the option for surgery, not initially, but I give them full medical management, and then patient is not responding. Then I give the option of surgery, telling them that this is not like a tonsillectomy or appendicectomy, that I operate you and you'll come fine immediately. It's a long-term treatment. Be in contact. You have to be like friends. I have to tell him nasal irrigation with steroids because I cannot give him steroids. I have to tell him about the possibility of using steroid and the side effects. Yeah, mostly they do agree initially, at least, and after 6 months, I don't know, sir, what happens. 6 months of follow-up, and then they start discontinuing their saline sprays and things. But yeah, this is how I tell them that it's a long-term thing, and you have to come. And I compare the disease with asthma, because asthmatic patients, they have to take their puffs and things. Similarly, they have to also take their nasal irrigation.
Gotamda, you have to add anything else? Anything to share?
Manish, it has been a very nice presentation. And yes, I do agree with you. The counseling part is always very difficult. And I picked up one line from actually PSN Murthy long time back. And I use it for AFRS patients, for CRS patients, and for open mastoid cavities. I tell my patients that we are going to be friends for life.
Yes, sir.
Each other off and on. That's what I tell them.
Yes.
Rest messages. Okay, sir.
One thing I want to mention, that the intraoperative bleeding is probably the root cause of, the unsuccessful failure. Yeah.
Yes, sir.
Because you have seen the difference when we operate, including myself. I'm not telling about you or all of us. There is plenty of bleeding, but you have seen Satish Jain operating, absolutely bloodless film.
So there's the
whole anatomy is in
front of anesthesia thing also.
The anesthesia thing, but he gave more stress on the local application again and again and again for 10 minutes, 10 to 15 minutes even he was telling that you have to keep on rubbing, this smoothly over the area for quite some time. And that only will give you a bloodless feel. It is not the injection or the anesthesia, pressure reduction. He gives more stress on rather heartbeats, number of heartbeats, than the pressure, increased pressure. He doesn't give much heat to the pressure rise, but he says that heartbeat should be normal at 60, 60 or nearby. So that is one very important factor, and probably we should give more time at the initial phase to reduce the bleeding. That is a very important thing.
Yes, sir.
Yeah. And what about the use of antibiotics? What different antibiotics you would like to use? Because you see that
post-operatively, I prefer giving clarithromycin, but nowadays I'm giving doxycycline also, amoxiclav also, depends. But I find clarithromycin very they're very comfortable with it, and so I can give it for long term.
Which situation you give clarithromycin? Which situation
my post-operative patients
doxycycline?
Mostly, sir, I know doxycycline is proposed nowadays, but personally in my practice I prefer giving clarithromycin in all this pre-op or post-op also, sir. But yes, we should because doxycycline has been used as a first-line medication nowadays.
Yeah, and for staphylococcal infection.
Staphylococcus, so we can add if there is, definitely, because sir, I frankly speaking, I do not use this thing, the culture, but yes, we can give linezolid. Linezolid is well tolerated. So what do you prefer, sir?
Yeah, that's what I'm telling. When the question of biofilm comes, then the staphylococcus is
biofilm.
That is the most important.
Then, yes, sir.
Manish, I want to add one thing.
Yeah, Manish, Dr. Fukan.
Yes, sir.
I think.
Actually, I asked you all the eosinophilic or neutrophilic. The question is for the antibiotic.
Sir.
Actually, for the report of the pathologist, you cannot rely.
Yes, sir. Neutrophilic.
If you see the total IG, it is high level, then it is eosinophilic. And if it is IG is normal, but complaint is there, it is neutrophilic. Then you go for macrolide. Otherwise, you go for doxycycline.
Yes, sir, macrolide.
There is the concept.
Yes, sir.
I'm telling that doxycycline does not work nicely in eosinophilic also. But the macrolide is a good immunomodulator and works nicely.
Yes.
But if it is neutrophilic, not eosinophilic.
No, sir, I'm just saying ki.
You have mentioned that it is neutrophilic, but IG, total IG, from IG level, you can, everyone tells that IG level has got no importance. But Satish and some allergologists told it has got importance.
No, sir.
For the immunotherapy result, for prognostic result, and for this choice of antibiotic also.
Exactly.
Thank you.
Rest are all complimentary messages from Akriba, Dr. Akriba, Devika Boro, and Dr. Fojia. So if now over to A.K. Boro, sir.
Thank you, ma'am.
Thank you, Anjana. So now we have come to an end of our session today. It was really a very useful and very good interactive session for all of us, and we have learned a lot of things, and we have came across all the discussions. And regarding one point, just at the end, I would like to read here regarding the doubt and allergic and non-allergic types of things. Actually, in some cases, when even when you find that in IG, maybe normal, but in the tissues. In the tissues of the dissected tissues, if we send it to pathologists and they find it that these are eosinophilic, and it is said that if there are more than 10 cells of eosinophil in a large, then I think
hypophil.
it will be yes, hypophil. I think then we have to deal it with the protocol of this allergic, basically allergic type of things. And in some cases, in most of the cases, as doxycycline is to be advised, because now even in COVID era, in COVID patients, we used to give the doxycycline because it, I mean, works in with interleukin, I mean, and 5 and all these things, and there is a lot of these are all these complicated things regarding immunology. So I think in some cases like this, we can go for doxycycline, and definitely clarithromycin is better in some cases because it is a very good immunomodulator. And that's what I wanted. I wanted to aid from just to which I came across during going through all the sessions in the YouTube or things and all these things. So anyway, I have nothing to say about it because all of you are very much knowledgeable, well prepared. So with these words, actually, I would like to conclude from my end actually, and I hand over, my microphone, or I should I request the Dr. Swagata Khanna to end up this session as the president of our association.
Yeah, thank you, Dr. Avidya, for a nice moderation, and my special thanks to Dr. Manish. You have presented your this work very nicely, elaborately, and I hope your lectures will definitely benefit our the upcoming surgeons, and the few things you have nicely mentioned regarding how to avoid failure of the endoscopic sinus surgery. It's a very good topic, and I think both speaker and moderator will cover the whole that the subject. I think thank you very much, and we'll see you in our next classroom.
Thank you, ma'am.
Thank you.
Okay, before I conclude, we conclude actually. I just wanted to share something.
Yes.
So, in the next classroom, our speaker is Anidita Das. She'll be talking on nasal analysis for septorhinoplasty, and moderator will be Dr. Swagata Khanna. I request Dr. Anindita and Swagata ma'am to have a session prior to the actual NABOL classroom so that we can restrict our timing. And while selecting a subject, actually, if it is a vast subject, if we cannot complete it in one session, we can have